Coping with brain fog. Oh, I may have jumped the gun, so I'm going to restart. Good evening and welcome to our virtual survivorship series number 2 titled Coping with Brain Fog. I'm Maureen Stannard and I'm a nurse practitioner in the Cancer Center working on the GI team. Before I introduce tonight's speakers, I'd like to ask you to please mute your lines, and you can use the chat feature that we'll be monitoring throughout the presentations for any questions that you may have tonight. So to introduce our panelists this evening, first we have Tom Griggs. He was raised in Norwich, Vermont, and recently returned with his wife after being away for 40 years. He worked as a forage crop scientist in Idaho, Washington, and Utah states before retiring as associate professor of agronomy from Western Virginia University. He was diagnosed with duodenal cancer in 2016 and underwent surgery followed by chemotherapy and immunotherapy, which ended in 2020. He has remained healthy and enjoys hiking, canoeing, cross-country skiing, and other outdoor activities, woodworking, and trying to improve family agricultural land. Next, we'll have Heather Wishart, who's a clinical neuropsychologist and associate professor of psychiatry and neurology at Dartmouth Health. She directs the neuropsychology program of the Dartmouth Cancer Center, and she also directs the brain imaging lab at Dartmouth Hitchcock campus of Dartmouth Health, and is a principal or co-investigator on studies of cognition in cancer and other illnesses. Rebecca Chow is an occupational therapist with a focus on neurological rehabilitation. She specializes in the treatment of adults in neurological-based diagnoses, focusing on physical and high-level cognitive rehabilitation, excuse me. So without further ado, I'll turn it over to Tom.
Well, great. Thanks for taking the time to listen to my presentation. I haven't had very many opportunities to really compare notes with other cancer survivors that have experienced some of these brain fog issues. So I don't know how common my symptoms and conditions really are. Next slide, please, Heather. So my particular case is in 2016, I was diagnosed with duodenal cancer, and I had successful surgery, followed by 6 months of chemotherapy, FOLFOX regimen chemotherapy, then I went about a year cancer-free, or apparently cancer-free. And then one of my checkups revealed recurrence of cancer. So I had 2 chemotherapy infusions, FOLFIRI this time instead of FOLFOX, followed by 2 years of immunotherapy with Yervoy and Opdivo. So that lasted 2018 to 2020. Somewhere in that first year, my wife, my primary care physician, and I all began noticing brain fog conditions, symptoms, initially as word recall problems and difficulty putting together coherent sentences. Next slide, please, Heather. So those were the main things we all noticed and that I was having a little bit of difficulty with, but at the same time and developing more in the next year, I felt like I was having difficulty communicating clearly with others. I could blunder through a conversation, but I often felt like I was substituting inappropriate words for the words I really meant, and I just couldn't pull out of the air. A general feeling at times, not all the time, mental dullness, slowness, little bit of loss of organizational skills. I felt like during normal social interactions, I was just a little bit less sharp at keeping up my end of the conversation than I used to be. And then the big one for me was I felt like I just was not functional in terms of keeping up with professional responsibilities, teaching and research, home responsibilities. Things were just getting to be a little bit beyond my grasp, not terrible, but a little bit. Next slide, please, Heather. So some additional issues, and these continue today. I feel like I'm less able to perform simple mental math calculations, simple subtraction, and I'm not as quick at adapting to changes in software and technology. Or if I don't use a particular software for 3 to 6 months, I find it more challenging to come back to than I used to. Definitely suffer from poor short-term memory, including conversations I might have had as recently as half an hour or an hour ago. Just can't recall exactly what I said or heard or agreed to. I also find in processes that take multiple steps, like making coffee in the morning, preparing to go on a trip, running errands, researching a product that we might want to purchase, getting a hold of a technical rep, I find I fail to ask all the right questions when I have that one opportunity. So next slide, please, Heather. At the time of chemotherapy and immunotherapy, I was aware of the possibility that brain fog might occur. And my assumption was that it would diminish with time if I experienced it. I've since learned that that may be a slower process than I had anticipated. I very much identified with an article I found in Scientific American or Science or one of the popular press science journals, and it was written by a person who had experience, who was recovering from major surgery. I think it was bypass surgery, but had undergone surgery and anesthesia, and talked about returning to adult league hockey practice, but showing up without his hockey stick periodically. And that really reminded me of the condition I felt like I was in. And that article, at least, it was termed post-operative cognitive dysfunction, POCD, perhaps as a function of the surgery, perhaps as a function of anesthesia or lack of oxygen at some point. But I feel like that's what I'm experiencing. My personal impression is my cognitive difficulties are relatively mild compared to many, or what many people encounter. But I also think they are in addition to what I would experience from normal aging. That's just my impression. Very much reassuring to learn from people in this group that brain fog is recognized by professionals and is being researched. Next slide, please, Heather. So I was finally offered some options for learning about and using strategies to cope with brain fog just recently, 2022. And it was partly a function of my primary care physician having performed some sort of a mini neurocognitive assessment. I can't really remember exactly what the test was, but it was an in-person short series of questions during a routine visit with my primary care physician. And then my oncology nurse practitioner, Maureen Stannard, and my primary care physician both referred me for neurocognitive assessment, which I received from Heather Wishart. And during that, I learned a little bit about possible coping options or ways to minimize brain fog or focus more specifically on fewer things and executing them well. So the strategy, and I'll come back to this at the end, I think my time's about up. My strategies to this point are making and keeping lists. I have lots and lots of lists, probably too many lists, and I have to rewrite my lists periodically. But I find it's very helpful to, if I'm going to go out and do a number of errands or try to combine a bunch of trips together, I have to refer to my lists. I try to focus on remembering specific steps that I'm going to do in a process, whether it's a woodworking process or a plumbing improvement, or trying to evaluate some data and summarize data, scientific data. I try to remember what are the steps I need to go through, and be mindful of how to get through them. Minimize multitasking. That's a difficult one to do. Review where I am and what I'm supposed to be doing continuously as I go through my day. I really focus on paying attention while I'm driving, because I feel like I could be very easily distracted if I'm talking with someone else. And the other thing that I do is I get a lot of energy from thinking about all the help I've gotten to this point, and just the fact that I'm still alive. That gives me a lot of just cause to celebrate. So I try to offset some of these problems just with that reflection. And I think that's all I have at this point.
Thank you, Tom. That was a really helpful explanation of what you experienced, and I think many people would resonate with that. I will go on to my set of slides. So I'm going to cover these topics. What is cognition and brain fog? So just starting with a couple of definitions. Why does this occur briefly? And then I'll try to focus more on what we can do about it. So first of all, what is cognition? It's really just a fancy word for thinking abilities. It's things like attention, concentration, memory, processing speed, planning, organizing, spatial skills, language skills, all of the higher cognitive functions of the brain. And what is brain fog? It's a decline or change in cognition due to cancer or its treatment, also known as chemo brain. But one of the things that we've increasingly recognized over time is that it's not just a chemotherapy effect. This can occur as a result of other factors as well. The commonly affected domains include recent memory. So like the examples Tom was sharing, concentrating for longer periods of time, word retrieval, so knowing the word you want, but it just won't come, or the name you want, it just won't come. And then multitasking, so where a person is finding that they can do things, but difficulty doing it if they're distracted or they're trying to do more than one thing at a time. So those are some of the commonly affected areas. Examples, a very frequent one people say is forgetting why you went in a room. Not recalling recent conversations, tip of the tongue, and difficulty concentrating on reading, work, whatever cognitively demanding activities the person has in their life, and multitasking. And these are things that everybody experiences. And I think the difference is that it's more frequent, it's more intense, and it's more interfering in somebody who's experiencing cancer-related cognitive decline. So why it occurs, it was a revolution when, some time ago, it was recognized that chemotherapy does have cognitive side effects. People didn't know that before. But then it's further revelations, as I mentioned, that it's not just chemotherapy. There are cognitive side effects of other treatments used for the treatment of cancer. And then also there have been studies looking at just the effect of the cancer itself prior to any treatment. And that alone can also cause some cognitive difficulties. So it's a a multifaceted causal pathway. And it's why you may see this term cancer-related cognitive decline coming up to sort of encompass this broader nature of what it is that people may experience. And then there are not just the cancer-related, but more indirectly exacerbating factors. So things like the fatigue, sleep disturbance, pain, stress, anxiety, mood disturbance, and then situational factors. So it depends a lot on where you find yourself and what the cognitive demands of that situation are. So if you're in a workplace, for example, that's very fast-paced, a lot of interruptions, a lot of demands, or the nature of your household activities, you've got kids and interruptions and more than one thing that needs to be done at a time, those are all going to be high cognitive demand type situations. So I think there are situational factors that have to be considered as well. And then what can we do? I think basically 3 broad categories of things that, that we can do. First of all, learn, assess, and treat. So in terms of learning, that's one of the things that you're here for tonight, just to gain some information and hear people's impressions. Discussing with your healthcare professional, I definitely think this is a topic to bring up if it's something that's bothering you. The Cancer Society website has good information, and then just discussing with family and friends what they've noticed and what they're thinking about your cognition. So basically trying to get some background information. And then in terms of what assessments are available, there are very brief cognitive screens like the one that Tom mentioned that his PCP early on did with him. And these are things like remember 3 words or drawings, things like that, that give an initial assessment, at least, of how a person is doing cognitively. Sometimes when somebody brings up and is mentioning cognitive issues, it will prompt further workup as well. So assessments might include lab tests to look for vitamin deficiencies, brain MRI to rule out other contributing factors, and a neurological evaluation possibly. And then it may involve neuropsychological testing. So that's where I'd come in. So neuropsychological testing, neurocognitive testing, those are the same thing. And if you were taking a neuropsychological assessment with me, which is pretty standard for what would happen, we'd start with an interview, which is just basically so I can get a sense of what you've noticed with your cognition, how that seems to be playing out. And if you want to have a friend or family member with you to sort of give their impressions, it's basically so that I get a good understanding of what it is that you're grappling with. And then we would dive into these standardized tests of concentration and memory and naming and so on. And it sounds a little daunting, I think. But while the tests are standardized and formal, the testing situation can be, I think, fun and interesting sometimes for people, and I try to make it as good an experience as possible. The tests themselves are things like I might, for testing short-term memory, I might tell you a short story and then ask you to try to say it back to me. Or I might show you pictures and ask you to try to say the name of it. And we would go through all of the higher cognitive functions of the brain. The evaluations can last anywhere from an hour for a quick, relatively quick in terms of neuropsychological timeframes, to several hours if it's somebody who's looking for work accommodations or disability assessment, or has more extensive needs for more extensive testing. And then once we're done with the testing, you go home and I start crunching numbers. So I'm going to take your scores on all of the different tests and compare them in 2 ways. One, to normative data from people in the general population in approximately your same age range. And then also to your estimated baseline, which I estimate as best as possible based on what you've told me about yourself, your strengths and weaknesses, and also some numeric estimators that we can use. And what it yields is an individual's profile of cognitive strengths and weaknesses. So I think everybody with cancer-related cognitive decline has strengths. And part of this evaluation process is to identify those, because those are things you can lean on and use to help compensate for areas that are weaker. And so, for example, somebody may have very strong language skills, but they are having more difficulty with concentration, or they may have very good practical problem-solving skills, but they're having more difficulty with some other area. So we try to identify both strengths and weaknesses. And then we'll go through differential diagnosis. So the question is your individual profile consistent with cancer-related cognitive decline, or could there be something else going on? Could there be, for example, that there may have been an undiagnosed attention deficit disorder that may have been there all along, or maybe is being exacerbated? We always look to see, could there be the early stages of some type of a neurocognitive disorder, such as a dementia? We look for these things and look in the pattern of test results to try to understand exactly what's going on. And then that informs treatment planning. So by the end of all of this, we would then have a wrap-up session where I would go over all of the results with you and any recommendations that stem from it in terms of further evaluation or treatment possibilities. And so in terms of treatment, what might happen? There's may be medication or supplements that would come into play. So for example, if we have identified another underlying cause that's causing your cognitive difficulties, then identifying those, working those up, and potentially treating those with medication, possibly. And then other conditions such as like an underlying vitamin deficiency, for example, supplementation. So that's one way things may go. I would work with you and discuss self-management strategies. So these are things that you may be able to do on your own and implement in your own day-to-day life. And usually we try to outline a menu of possibilities that you can then kind of pick and choose and see what seems to work for you and what you can adapt. So in terms of self-management of cognition, probably the single most frequent recommendation that I will go over is switching from multitasking to monotasking. So we often, and all of us do this, is try to, take on maybe more than is possible at one given time. And it can be a very powerful technique to switch to monotasking. So breaking a larger task into smaller steps, focusing on one step at a time, and then taking frequent rest breaks. And sometimes that can be a helpful, at least starting point for people in terms of the strategies that they may be able to use. And also thinking about things that they may be able to do on their own to help manage fatigue and energy in terms of energy conservation and pacing, and mood in terms of trying to build in pleasurable and enjoyable experiences. And then also taking a good look at potential situational factors. So is there something about the environment that you could change that would also help bolster and allow your strengths to come through? And then for people that will need more assistance with implementing strategies, or need a more intensive type of intervention and a broader based practical problem solving kind of intervention, we would very often refer on to occupational therapy to pick up, which is a profession with many evidence-based strategies that are very, very helpful for cancer-related cognitive issues. So just to sum up, brain fog is really changes in thinking. There are particular areas that seem to be most affected, such as multitasking, concentration, short-term memory, word finding. It's due to the cancer itself, most likely, and or the treatments. And in terms of what can be done about it, I think there's a variety of options, starting with coming to a meeting like this, learning, getting your arms around what it is you're grappling with, mentioning to your nurse practitioner or your oncologist, your primary care physician, and then trying to see where there may be strategies that you can implement or that you can be referred to learn additional strategies or get further workup and really get a handle on what is possible to help address your cognitive issues. We'll turn it over to Rebecca.
Thank you, Heather. I appreciate everything you've said, and I will kind of take it from the OT side. So oftentimes, once you have gotten a neuropsych evaluation, or, perhaps maybe you haven't even gotten in for an evaluation, you're waiting for an evaluation, or, an evaluation is not even on your radar quite yet, that is at any point in time you could be seeing an occupational therapist. So Heather, you can go next slide. So my objectives today are to help everyone to better understand cognitive deficits after cancer and treatment. I'd like to review OT's role in treatment, better review the evaluation process and common treatments, as well as what we do as occupational therapists. Next slide. So the Mayo Clinic defines what are cognitive concerns after cancer treatment. The Mayo Clinic defines that as changes in thinking, memory, attention, processing, and executive functioning skills. And what are executive functioning skills? That's a broad umbrella term for things like planning, problem solving, sequencing, managing your priorities, regulating emotions, self-monitoring, time management, and organization. Next slide. So where OT's role is within occupations, and occupations are the following. So you can see I've listed them here. There's 8 areas of occupation, but basically what occupations are not just, work related or anything like that, but they're anything that you need to do, are expected to do, or want to do. And they fall within these broad categories. So we've got a lot of leeway in what we're treating and what we're looking at. And really the focus is on what is important to you and what you want to get back to doing. Next slide. So our focus and my focus really, when people are coming to me with a cognitive decline, from cancer or treatment or other kind of, issues that they might run into, my focus really is on what is the functional difficulty you are experiencing at the time. So some of these functional difficulties might come through as difficulty managing a daily schedule, recalling and taking your medications correctly, arriving on time for events, or managing your calendar, taking care of yourself or others. That goes from, the broadest way or the most, basic activities of daily living. So getting dressed, if there's a sequencing issue, we forget to put on a certain article of clothing and we put the other article of clothing on first and we walk out the door, all the way up to, caring for a child or caring for an elderly, parent that you have to take care of, driving, of course, working, organizing thoughts for communication. So having conversations with people and really having those, engaging conversations where you're able to have a nice back and forth and you feel like you're an active part of that conversation. Cooking, and of course, caring for pets. Next slide. So how does the OT evaluation get started? So how you get to me is that, again, you might see your primary care doctor, any of your MDs or nurse practitioners, PAs that are part of your treatment team that can really be your PCP. It can be, someone part of your cancer treatment team that says, hey, you start that discussion with them and, you say, hey, I'm having these cognitive concerns. They can place a referral for occupational therapy. And how that interview process how that evaluation process would go would really just be similar to Heather. We have that initial interview process where I get to know you, get to know what's important to you, what drives you, what your passions are, and what you really want to get back to doing. And after that initial interview process, we jump into the screening tools. So I favor screening tools that are 10 minutes or less on the first day. So I will kind of not throw too much at you at once. And it just gives me an idea of where to go for additional testing. So it helps me to say, okay, are you having issues with your memory, attention, any of these executive functioning skills, and then we move forward with additional testing from there. And some of that testing will look like, similar kind of performance areas that you might have in the neuropsych testing, but all of this is function based. So some of the things in the performance areas I'm looking at are all based on, functional things you might encounter in your daily life, but they are, they have norms, they have data, there's a lot of research behind them. I just want to know how they're affecting your daily lives. So, and then the last part of the evaluation is collaborative goal setting, really getting to know, like I said, what is important to you. And that is really what OT is all about. And that's, why I love OT. So if we can find out what's really important to you, we can work on those areas that you're not doing so well in right at the moment, and we'll work toward improving those areas. And then we'll work toward also some of those compensatory strategies as they relate to things that you have to do or your occupations. Next slide. So really, I once we get all of the testing done, which sometimes takes several sessions, so you will, I typically see people for several sessions. I can see people for several weeks, up to months. I can see people for, a month or 4 sessions. It really depends on what you need and really what you want to get out of this. So once I get all of the testing completed and I have a good idea of where you're at with your function and everything, I'm going to look through all the assessments and the results, and then I'll look at what I can do for remedial strategies, meaning trying to really address exactly what's going on and trying to address and improve the deficit you're having with your cognition at the time. But at the same time, I'm also going to be looking at what we call compensatory strategies, or ways to compensate around those deficits you're currently dealing with to get you through your day with improved ease. Next slide. So I provided some very, very brief and broad examples. But some of the things you might do with me after we complete all the testing is, if it shows that you're having difficulty with specific parts of memory, maybe that might be visual memory or, verbal memory, or things, that don't feel quite right on your day-to-day basis, we can talk about those very specific examples that you're dealing with and review memory strategies and practice using them within our clinic. So I really try to make things very relevant to your life and, really work toward things that are important to you. Another example might be if you're having attention difficulties. Again, Heather touched a little bit about trying to go from doing multiple things at once to one thing at a time. And that's one great example. And a big part of what I do is really look through your attention score testings and say, hey, you may not be able to do all of these things all at one time, but maybe you're really, really good about sitting and doing one task for a very long amount of time. So let's go through that and see what that looks like. So maybe drawing out a cooking task for, an hour where it might have taken you half an hour prior, but what does that look like? And, maybe we're getting that perfect recipe and we're super happy about that. And we can still achieve our goals. It just might be in a different way. And a big part of what I do is really building awareness into the deficits, and so that we can improve that occupational performance. So that's performance in things that you want to do, need to do, or are expected to do in daily life. Next slide. And so again, what are the goals? The goals are anything that is really important to you that you want to do, need to do, or are expected to do in your daily life. And the way that I do that is it's a collaborative effort between the patient, myself, and if you want loved ones involved to help to kind of facilitate some of the recommendations and things we practice in clinic, then that is a wonderful thing that I welcome all the time. So some more examples of specific goals people have brought to me are, they'll say, I really want to get better at reading my favorite books. I really just have a hard time with that reading comprehension. There's ways we can go over strategies to improve that. We can practice it in clinic. Maybe the auditory memory is really just where we're struggling right now. So we'll work on listening to audiobooks and the comprehension behind that with strategies to improve the performance of that. Sometimes there are return to work goals, and we work a lot through some strategies to help augment and help build you up in order to feel really confident about doing some of those work-related tasks. And then, of course, we do help with things like cooking and cleaning and organizing a schedule, and using some of those external strategies like timers and all those fun things that help to get through our day. So that's all I got. Thank you.
Thank you so much, Rebecca. That's amazing work. That's great. And I'm just going to move on to Tom again.
Tom, you're muted. Sorry, we still can't hear you.
Thanks, Maureen. Sorry. Can you hear me now? Okay. It's been very interesting for me to listen to these presentations, and I'm realizing that I really haven't explored very many of these options yet. So I feel like I only recently discovered that there are treatment options, even though I've been experiencing these things for years. I would say the approaches that I've used the most and or that have been the most successful for me have been certainly minimizing the multitasking, trying to transition towards monotasking has helped. Part of that, though, is that means I tend to forget some of the other pieces that I might normally kind of include if in a thought process if I'm multitasking. So I have to make sure I go back and pick up those other individual tasks that I set aside. And so I use lists or some sort of obvious placeholders. Like if I have to go paint, I'll actually plant a can of paint in the mudroom or on the kitchen floor as a reminder that I have a project to do. I try to just be mindful, particularly during conversations when I'm trying to learn something from someone else. I try to be really mindful of just paying attention, being a good listener, trying to integrate that information in a way that I'll be able to recall later. Still learning how to do that. I'm only employing a few of the treatments that Rebecca mentioned, and so I'm curious about maybe trying to include a few more of those. I guess I really don't have much more to add.
That's okay, Tom. I'll ask some of the questions coming in through
Yes.
the chat.
Yep.
So it looks like a number of questions that we're seeing are related to insurance coverage, and I don't know the answer to that. Does insurance cover both testing and treatment?
Neuropsych testing is usually covered by insurances. It's covered by Medicare and Medicaid. And in terms of private insurers, we usually recommend to people to check their individual with their individual insurer themselves, just to be sure, because the plans are so varied. The hospital does, in our case, our hospital does do a verification of insurance, but we still would generally suggest to people just check and make sure.
Is that true for you as well, Rebecca?
So yes, typically, so I actually previously worked at Dartmouth. I no longer work at Dartmouth. I work at a private outpatient physical therapy and occupational therapy clinic in Southern New Hampshire. And we take all insurances, Medicare, Medicaid, as well as private insurances. Well, I shouldn't say all insurances, that's very broad, but most insurances. And yes, definitely covered by Medicaid, along with treatment and testing for OT.
Great. And Tom, was your experience that it was smooth once you deemed that your insurance would cover this?
Yes, it was. I had no problems with coverage. I'm on a Medicare Advantage plan through Humana, and it went right through.
Great. So another question is, how do I set up testing for this? I believe you need a referral, Heather, is that correct, from one of your providers? So you would talk either with your oncology team or with your primary care provider.
Yes, we do require a referral, in part because that starts the insurance verification or insurance coverage process. And also, I mean, people would be welcome to just contact me, for example, if they think they're interested in neuropsych testing, to just sort of see how they can get that referral in place. But yes, if you're seeing your oncologist or you can contact your PCP. Basically, anybody in your care team can make a referral.
Great, thank you. Another comment here from Richard is, excellent webinar today. I'm almost 2 years out after my last chemotherapy. The brain fog issue does affect me as well. Being retired, how much of what was discussed today is covered by insurance? So I think we just covered that piece, but I am wondering, thinking of retirement, a question that I had listening to all of this is, once you finish chemotherapy and all the number of extra appointments and extra medications and all of that, and kind of shed some of your responsibilities. I guess I'm kind of addressing this to Tom, but anybody that wants to answer it. Did you feel some of that resolve? Did any of this resolve when you got rid of some of the stressors in your life?
Yeah, some did, but I have a horrible habit of taking on more responsibilities. After, as I shed A and B, I take on C and D. So I'm still behind in everything I touch, and my lists are way too long. But I feel like I have more freedom to kind of say no and let some of them fall through the cracks, because I'm not being paid to do them.
Good. Okay. Another thought that I had relative to work responsibilities, as a clinician, I feel like I see patients hesitant to talk about their cognitive issues, and I am guessing that it's multifactorial, but I'm wondering how much is people worried that it might be something worse, like has your cancer progressed to your brain, or is it something that people worry that they'll lose responsibilities, that they may be demoted at work because they're showing some cognitive issues or fogginess,
Yeah.
And they're not safe with handling money, or safety issues if they're managing tools, or legal ramifications or whatever. Can anybody on the panel talk about some of the hesitancy about reporting?
That's a really common thing that I see with people. So there's a hesitancy maybe to bring it up in an oncology appointment, because they think, well, I'm here to get my medical care. This thing I'm dealing with isn't necessarily something that, but it is a very legitimate thing to bring up. And then in terms of bringing it up with work, that is definitely a tricky situation. And as you say, I think it's going to be an individual course. Everybody's going to be a little bit different. As part of, and then I'll ask Rebecca, but as part of the neuropsychological evaluation, we can certainly come up with accommodations requests. And typically we would do those in connection with your oncology team, so that it's coming from your entire team. And I would wind up having quite an in-depth discussion as to what the definition of reasonable accommodation would be in your particular workplace with what you know about the workplace, so that hopefully we're coming up with an accommodations request that's very reasonable. And as part of that, trying to be very sensitive to the fact that people do not want to give necessarily an impression that they're having difficulties that might interfere with their work. So it's certainly something that we try to be very careful of. And also there are certain rights that people have. So you do not necessarily have to disclose medical information in order to make accommodations requests. So I think that, it's to look at the individual workplace, what's the definition of reasonable, and just how much disclosure a person feels comfortable with. Those are all part and parcel with what goes into those return to work.
Rebecca, are you going to add something as well?
Well, no, I think she said it perfectly. And honestly, from my standpoint, I work a lot with the referring provider or, the provider that they're most comfortable with regarding these return to work concerns, or, hey, I'm not really doing my job as well as I can be. I work a lot on some of those strategies to help people to achieve success wherever they are, including work. So we go over that sometimes in clinic. I give some homework sometime to do at home. A lot of my testing is sent to the referring provider so they can have a better understanding of functionally how are they doing in their day-to-day life. And that helps the referring provider or their provider make some educated decisions on work, or if they need to, go toward neuropsych testing or a functional capacity evaluation, which is a whole separate return to work readiness examination. So there's a lot of options from there.
Great. Tom, anything you wanted to add?
Well, I may be an unusual case because I had an extremely supportive work environment at West Virginia University, and I felt very comfortable discussing all of my conditions with others who were having health issues. Most people have had some sort of a health issue, and so I just found there were all kinds of educational opportunities to discuss and compare notes. But I can well imagine that environment wouldn't be that wouldn't be the same environment in many workplaces. So I didn't feel constrained in discussing these conditions and treatment possibilities that we're all talking about.
Good. Another question coming in through the chat is from Emily. How do I deal with chemo brain when I have to take chemo pills for the rest of my life with no end date? My cancer went into my lymphatic system and I will have chemo for life. I'm going to jump in a little bit on that one first, but anybody from the panel can come in behind me. I think it will be an ongoing process like your ongoing cancer treatment. As it can go parallel with treatment. It doesn't have to be once you stop treatment that you can tend to these cognitive issues. It can go parallel and your needs may change over time. But it can certainly, these are strategies that you can use the whole time you're taking treatment. Anyone else?
I'll just jump in quickly, and then Rebecca, the way we designed the neuropsychology program at the Norris Cotton Cancer Center is specifically for longitudinal care. So that once somebody starts with me or with us, it's meant to be able to go on and adapt to changing needs. And I know that that's the case also for OTL.
Certainly, yes. A big part of what we do is adapting and changing, and the strategies might change based on where you're at. and we're very adaptable to that. I've had people that come and see me, 2 years ago, they come see me again 2 years later, and then, we redo the testing. We see what strategies are working or not working. If they see a decline in their functioning, or if they feel like they're doing a whole lot better, there's similarly to what Heather was saying, there's a lot of variation in what I do as well.
Hopefully that answered the question. I'm not seeing anything else right now in the chat. Another question that I had coming through before we wrap up here is some talking about aging in the normal aging process versus from outside influences. And
Right.
I think, especially with this question from Emily, we are aging while we go through this. Does it get hard, Heather, to sort out what is what? Or can you see that pretty clearly in your testing?
It's a little tricky, but because we use age-based normative data and also baseline comparisons, we can, to some extent, and often are called upon to try to distinguish cancer-related cognitive decline from effects of aging and from incipient major neurocognitive disorder, or also known as dementia. So that's a common differential diagnosis that we do. And so we do have some tools for trying to sort that out. And sometimes that also includes getting a baseline and then a reassessment down the line.
Okay, so that would speak as well to Emily's question of needing chemo over time, over a long period of time. One final question that came in is, what's the panelist's thought on Prevagen, which is a medication used to help slow memory loss?
I would actually defer to you, Maureen, if you have, it's sort of outside the medication is kind of outside my scope of practice, really.
Okay.
Yeah.
Yeah, and I'm seeing Rebecca. Unfortunately, I don't have a lot of experience with that, so I'm not going to be a good person to answer that one. I don't know that medication very well.
If that person would like to contact us, though, I'd be happy to find the answer and get back to them.
Yes, exactly. That's I am happy to take care of that. So Jackie, if you could send in your contact information privately, that would be great. Okay, folks, I think this is the end of our presentation for this evening. I think it's been a great presentation. I hope the audience members have all appreciated it as well. It has been recorded, so it will be available through the website and on Facebook. And we hope that you'll join us next Thursday for a presentation on different research studies that have been done about survivorship and survivorship issues. Okay, have a good night, everyone. Thank you very much, panelists.